So today I'm representing Christobel Saunders. I'm Claire Johnson, Health Services Researcher from the Cancer and Palliative Care Research and Evaluation Unit, of which Christobel is our Director. Christobel is unable to be here today, and I was asked to talk to her particularly about breast cancer research to start with. Christobel's research ranges across disease trajectory, the whole disease trajectory, and explores etiology and risk factors right through to cancer control, survivorship and outcomes research, and now health services or health systems research, of course. Christobel is emphatic that research should be followed through from conception, development, implementation and evaluation into the clinical setting. I'll briefly outline several projects from the various CSO areas in which she is currently working. So just looking at etiology and risk factors, way back in 1993, concerns about breast cancer and pregnancy were raised in a review by Christobel with Mike Baum. This led to the WA Gestational Research Cancer Project, which explored 2,500 cases of gestational diabetes, cancer of course, wrong disease group, who were identified between 1982 and 2003. This was the subject of Angela Ives' PhD thesis. Hospital administrative data was linked to pregnancy and birth data, pharmacy data, pathology data, midwives' records, and imaging and chart reviews were also conducted. The results found that compared with other young women diagnosed with breast cancer, survival was similar for women with gestational cancer. As a result of that research, pregnancy is no longer contraindicated after breast cancer. Guidelines and patient supports have been developed to help women who have gestational cancer. Amongst the ongoing research that Angela and Christobel are involved in is the POSITIVE trial, which investigates the endocrine therapy interruption to enable conception for young people with estrogen receptor positive breast cancer, which is an international trial. In terms of prevention, estrogen is a key carcinogen, and aromatase inhibitors have proven of benefit in adjuvant setting in both recurrence and new contralateral tumours, but back in the 90s and early noughties had not been investigated for chemoprevention for women at high risk of developing breast cancer. An international RCT of anastrozole versus placebo for chemoprevention in women who were aged 40 to 70 years who had an increased risk of breast cancer was conducted. Breast cancer rates were halved for women in the anastrozole group. No difference in cancer or cancer deaths was detected. There was no concern, but there were concerns about side effects and compliance, with the side effects in the anastrozole group significantly higher. Few people are taking up chemoprevention, and we need to explore more thoroughly why this is not occurring. Right. Looking at the early detection, diagnosis, prognosis research space, Christobel's working with the OBEL group, in particular with Rob McLaughlin, in the development of optical coherence tomography. OCT is analogous to ultrasound but uses near-infrared light instead of sound. But OCT only penetrates 1 to 2 millimetres, so needle technology is being developed. This involves the development of a miniaturised OCT needle probe being encased in a hypodermic needle. Ultrasound-guided OCT needles can be used to assess tumour margins and provide images of actually how breast feels, which changes, of course, with disease. OCT provides higher spatial resolution and sensitivity than traditional imaging. Applications for venture capital have been submitted, and clinical trials development is currently underway. Under the CSO for treatment, some people may have heard of the TARGET trials. Risk-adapted radiotherapy involves a single dose of intraoperative radiotherapy with intrabeam versus fractional external beam radiotherapy. Intraoperative radiotherapy is preferably given at the time of the initial surgery, but if there is adverse pathology, external beam radiation can be added at a later date. An international RCT was conducted with women with unifocal invasive breast cancer. Results showed that the targeted radiotherapy during lumpectomy is as good as several weeks of whole breast radiotherapy. Those in the target group had lower radiotherapy complications, less pain, and a better quality of life. There were fewer deaths from other causes, such as heart attacks and other cancers. Target radiotherapy has just been accepted by MSAC for a Medicare item number to be allocated. And the next step, of course, is routine implementation into routine practice. So the next area of consideration is cancer control, survivorship and outcomes research. A number of exploratory intervention projects are currently underway, such as research exploring women's experiences of contralateral mastectomy, patient-reported outcomes after DCIS, hospital morbidity data study analysing presentation of patients in the emergency department after receiving chemotherapy, investigation and outcomes of the Managing Menopause After Cancer project, and exercise for chemo brain. In fact, Christobel is part of a Centre for Research Excellence on exercise and lifestyle in the management of breast cancer and gynecological cancers. Which brings me to outcomes and health services or health systems research, which incorporates aspects of translation and is the focus of CAPCRU's research. This is still a relatively new field of research and is not always well understood. Broadly speaking, health services or health systems research is defined as a multidisciplinary scientific field that examines how people get access to healthcare practitioners or healthcare services and how much care costs, what happens to patients as a result of this care. The ultimate goal is to maximise patient outcomes by improving the function of the health system. It involves both non-intervention and intervention studies, and the unit of research may be individuals, families, organisations, institutions, communities and populations. In our setting, the focus is on improving outcomes for people diagnosed with cancer, but can target any point in the cancer journey. Health services research may investigate any of these areas, looking at how we might improve outcomes at the systems level, get research findings into policy and routine practice, develop and evaluate new models of care, access and timeliness of interventions and access to services, appropriateness of treatment, care and healthcare provider access, maximising the uses of resources and developing an evaluation of care pathways. All of these may include the inclusion of new treatments, their cost and evaluation of them in routine practice. This is the field of research that we're particularly interested in and where collaboration is imperative, with policymakers, service administrators and clinicians needed to make things happen.